Well, welcome back to our Cardio Ohio podcast. I'm Ellen Sabick, your host, and today I'm here with our co-host, Dr. Ann Albers. Welcome, Ann, to the program.
Thanks, Ellen. Good to be here.
So today we're actually going to be talking about our pharmacists and how the pharmacists have really stepped up and become a very integral part of our cardiovascular team. And because of that, we're actually really lucky to have Dr. Kelly Barsh from the Ohio State and Dr. Megan Lebrecht from Ohio Heart joining us. So before we get started with our topics, Kelly, can you briefly talk about your professional journey and how you ended up doing cardiovascular or a prevention concentration at OSU?
Sure, I'd be happy to. So mine really starts when I was a resident. I matched at the Columbus VA, which is all outpatient, and was fortunate to have some great preceptors in some very cardiology heavy areas like anticoagulation, lipid clinic. So they really got me kind of started on that road. I've been at OSU since the end of my residency. And again, the clinics that were available at the time were very cardiology heavy. This is where I started and where I've been fortunate enough to continue through the years in various different parts of cardiology.
Great. And Megan, can you give us a little bit of your background on how you got to be on the cardiology team?
Absolutely. First, thanks for having me today. I am an ambulatory care specialist at Riverside, focusing on atrial fibrillation and antiarrhythmic drug therapy, as well as stroke risk reduction. My journey into AF management really began through a passion for optimizing medication therapy and helping patients navigate complex cardiovascular conditions. Over the years, I've become a part of this multidisciplinary electrophysiology team. So I work closely with patients and providers on stroke prevention and rhythm management, especially with a focus on med safety and education. What I love most about this space is the opportunity to build lasting relationships with patients and demonstrate the impact that pharmacists can have on outcomes. And this really started just like Kelly as a resident when I realized that ambulatory care was going to be a great focus of mine. I have always loved cardiology, and so I was able to marry the two, starting off with anticoagulation management and navigating into this space in 2019.
Thank you to both for talking about your professional journeys. I always really find that quite interesting. And Megan, you actually touched on a lot of things we're going to be talking about today. So I'm really excited for our topic. So when I first think about when I knew that our pharmacists have become such an integral part of our cardiovascular care team was several years ago when at University Hospitals we started a DOAC clinic where we consulted our pharmacists because as so many of our older patients have AFib and they need anticoagulation. And really early on, the DOACs were not particularly affordable. And so our pharmacists stepped in and really helped find programs that helped our patients be able to afford their medications. And that's how it started, was initially with the DOACs, but really that evolved to cover various heart failure medications because we know we have our GDMT, which if they're not covered by insurance, or even sometimes when they are covered by insurance, they're really quite expensive. So I guess we'll start first with Megan. Can you discuss what programs are available and open to our patients, and how do you help these patients figure out a way to afford their medications?
In our practice, much like I'm sure at UH and at Ohio State, we utilize several different resources to improve affordability for patients. We have hospital-based patient assistance programs that helps overall with not just medications, but hospital costs as well. We do have our own outpatient pharmacy located within the walls of our hospital that help affordability in terms of contract pricing. Some of our hospitals within our network do have the 340B pricing, which does help with costs for some of our patient populations. We do have medication assistance teams that can help navigate these barriers. We do work closely with manufacturers as well in these outpatient clinics to find medication assistance programs in which patients would qualify for those, and that we can provide assistance in getting those applications started, and which again help identify which patients are appropriate for those. And another important tool that I've learned that I know I did not know about a decade ago are these foundation and grant based assistance programs. So many cardiovascular medications, especially in our heart failure spaces and some specialty medications like our amyloid setting, they may be supported through a charitable foundation to help offset some of these costs. And these are especially valuable for Medicare beneficiaries who do not qualify for manufacturer copay cards. And so I think that this is really important for patients when it comes to help cost savings, especially if there are not therapeutic alternatives that are more cost effective.
Now, Kelly, being part of the Ohio State and basically a state institution, are there additional, any sort of government programs that your patients might be open to that might not be available to other sort of more private pay insurances?
Yeah, I think fortunately the answer is no, and that those programs are available regardless of whether you're seeing patients at a state institution or not. There are a couple other resources that we tend to use. One is free pharmacies or charitable pharmacies, which most major metropolitan areas have at this point. These are pharmacies that connect with manufacturers to get drug at very low cost or free, and then in exchange can give patients those meds for free, typically if they meet certain income requirements. That has been a very useful resource for many of our lower income patients. And then I think the thing that kind of gets lost here is for many of our Medicare patients, they're not eligible for a lot of the copay cards, but there is something called cost smoothing available, typically more helpful at the start of the year, but patients can enroll and it takes their total deductible and evenly spreads it across the year instead of giving them these huge upfront costs in January and February. So especially for patients that are on more high dollar drugs, it has been a very useful tool to make things at least a little bit more affordable for our older patients.
Wow, that's great. Actually, I can imagine how cost smoothing makes a huge difference for somebody on a fixed income. One question I have is how can I, as someone who refers my patients to the pharmacist, prepare the patient for this kind of a visit? Is it some, because I usually will tell them this might just be a virtual visit. You usually don't have to come in, but you might be asked several financial questions and have some resources available just to make the appointment more productive, and also so they don't feel surprised when someone starts asking them about financial information.
Sure. Yeah, I think there's a few ways you can go about it. Most patients know that drugs are increasingly expensive. And I feel like if you've had a solid discussion with them about why a specific medication is needed and you're upfront about, hey, this is going to be high dollar. I'm going to connect you with their pharmacist and they can work with you on what might be feasible option. Every option that Megan mentioned that I talked about has slightly different income requirement. So there's no hard and fast rule of if you make X number of dollars or you're at a certain point compared to the poverty line, you're automatically in or you're automatically out. I think it's fine to just generally prepare patients to say, hey, they're aware of some more options. They'll try their best to get you connected to them.
I also think that it depends based on your institution as well. If you're referring a patient to the pharmacist, it also might be for management of certain medications, not necessarily just finding the most cost effective option to get the patient on an important medication for their disease state. And so I think that in that regard, if the patient is coming, for example, to a lipid clinic for initiation of a high dollar lipid lowering medication that's important for their cardiovascular risk, I think that having that discussion that the pharmacist plays an important role in optimizing these medications that are recommended by the physician, and they have the ability to monitor some of these things a little bit more closely, especially the obtaining and follow up of a prior authorization, for example, knowing that has a specific the pharmacist has a specific role in the workflow of the care team, I think is important to call out. Oftentimes, patients may not know why they're seeing a pharmacist or why that visit may be important face to face due to needing to obtain blood work, for example, or maybe needing to obtain some diagnostic testing. And so I think that is also important depending on where the physician is referring the patient to or what kind of clinic. And so I did just want to mention that just because it does best prepare the patient if it is a face to face visit.
Thanks, Megan. That totally makes sense. And it leads right into a topic I wanted to touch on, which is I don't even know how much patients are aware of this, but prior authorization. It's such a team-based effort when we have to go through prior authorization for medications for patients. So whether it's the pharmacist, pharmacy techs who are best positioned to help with these prior authorizations for the specialized medications that can have such an impact on someone's cardiac condition and how we can lower their risk. And I guess it definitely seems to be through pharmacy that we get the most information about insurance regulations and preferences or guidance for whether we start with PCSK9 inhibitor or inclisiran as next steps for lipid lowering. And obviously, coverage and cost to the patient play a role. But Kelly, maybe could you just speak a little bit to the kind of how cardiovascular prevention and lipid management, how that clinic is at OSU and how you guys add to that for patients?
Yeah, absolutely. I think many pharmacists are well positioned to have good connections with our industry access team, maybe have a little bit better handle on which insurances tend to prefer different things or what's better served, for example, with inclisiran being billed through medical insurance versus commercial insurance for Medicare patients. I think there are some other kind of general tools that we probably utilize a little bit more as pharmacy, but are available to physicians typically as well. Increasingly, our like IHIS or other work systems have the ability to price estimate or to suggest if a one medication in a class is preferred over the others, which is increasingly accurate and can help minimize the need for prior auth or make sure you're choosing something that's more likely to get approved. I think another thing that's often overlooked is how much good documentation smooths that process. I know we tend to put supporting references, the citations in our notes, make sure we clearly note what medications patients have tried before. And oftentimes, pharmacists, we get a little bit extra time with patients, so we have a little more time to get that all written down and worked through. But certainly, from a provider standpoint, if you're trying to do this solo without a pharmacist, that would be a place to start as well, would be to make sure that your documentation is solid and that you have noted what people have tried and why they've failed it in the past. I know at OSU and certainly a lot of the bigger institutions, we are a bit spoiled. We have a specialty pharmacy, and then we have pharmacy techs that are specifically dedicated to doing the actual submission piece for prior authorizations. We kind of get everything teed up, and then they take care of getting it entered and following up to make sure we get a determination and then get us re-involved if appeals needed or to implement the plan after that.
That is so helpful. And Megan, can you comment a little bit on what we have at Ohio Health?
Absolutely. Our pharmacists in our lipid clinic specifically practice very similarly to that of Ohio State's optimized lipid lowering therapy. And so, again, just like Kelly mentioned, our specialty pharmacy, we utilize the techs there to initiate some prior authorizations as well. We have some processes within our advanced heart failure clinics and a dedicated prior authorization team for our advanced heart and vascular center that encompasses a couple of different clinics. So they can help set up prior authorization needs for some specialized medications, for example, amyloid or pulmonary arterial hypertension. And so the pharmacist isn't exactly, they're there for appeal need, just like Kelly mentioned, but not necessarily doing all the paperwork for that. And then the pharmacist is available for education and availability of grant-based assistance programs or manufacturer assistance programs. And so we utilize those sort of workflows as well. We do have a dedicated social worker within our advanced heart and vascular center. So they are able to identify patients in need of these services, especially if insurance changes or someone's maybe lost their job or needs to apply for some sort of hospital benefit for their cost reduction.
Wow, thank you. I have to say, our pharmacists and our pharmacy techs certainly have really changed the game and made it much more streamlined. And I think our prior authorizations to obtain meds has really become a lot, not only streamlined, but much more successful. So I certainly am very appreciative of all this. Now, speaking of education for patients, we're going to turn on to a slightly different topic in that there's several medications, as you even started mentioning, where they need maybe a titration for various doses based on side effects and based on therapeutic effects. They might need various blood work follow-up, etc. And a lot of times, for example, the GLP-1s, GIPs, a lot of times my patients know they want to be on something and they do have several cardiovascular indications. They may have heart failure, preserved ejection fraction, sleep apnea, etc. So what I will do is I refer them to our pharmacist and I said, this is for education, prior authorization, initiation, and titration of the meds, because you all do, I think, a lot better job of educating the patients on what are the potential side effects. And when they do have side effects, you are very good at either reassuring them, saying, yes, but this will be temporary, and you can hold their hand and take them through their course. So they're actually more likely, I think, to stay on those medications when we have the support of our pharmacists taking care of all of us. And I think the patients have really been quite happy with that. And in addition to, let's say, the GLP-1 GIPs, also for heart failure medications as well. We have our 4 medications that we have to start. They all have effects on blood pressure, heart rate, etc. And so to somewhat rapidly titrate these up, but still have touch points along the way, it's much more effective either with our pharmacists taking care of that, or in our heart failure clinic, sometimes we have nurse practitioners who see our patients on a very frequent basis. But what programs do you have at Ohio Health, either in heart failure or cardiometabolic disorders, et cetera, for these types of med titrations?
So at Ohio Health, we do have in our Advanced Cardiovascular Center, we do have a GDMT titration clinic where, just like you mentioned, the patients with heart failure with reduced ejection fraction or even with preserved ejection fraction that need titrated on certain medications will be referred to the pharmacist for titration after initiation. And they do have nurse practitioners well incorporated into their team. And while the pharmacist is able to titrate those medications with frequent telephone follow up, the providers are able to see more acute patients, which of course allows wait lists to decrease in time. So new patients can get sooner follow up. And the heart failure pharmacists are able to initiate GLP 1s and follow those titrations as well if referred by the provider. We also have a consult agreement in our institution for IV iron for patients in our heart failure specialty, as well as pulmonary arterial hypertension. So, for the, of course, and aside from our lipid clinic and cardiometabolic clinic for overall lipid reduction and weight management. So, those are our cardiovascular care services that we currently have at this time. And I think the IV iron one is really incredible because we know how beneficial that is in patients with heart failure.
Oh, that's wonderful. Kelly, how about at Ohio State? Are there particular programs in the different cardiovascular service lines that you have specialty clinics for that? And also, how do you keep your CD clinicians in the loop? Do you just forward notes? Do you send them haiku messages, or how does that work?
Yeah, it's pretty similar to what Megan talked about that they offer as well, GDMT titration. I think other kind of more niche areas include even things like statin intolerant patients and titrating them rather than them needing to come in repeatedly month after month, being able to do some of that via the pharmacist to get them quicker to a goal target dose, as well as things like blood pressure management or remote patient monitoring of blood pressure and adjusting those meds. So it's pretty diverse. I think when we think about how we keep the clinicians in the loop, there's also another kind of sub thought to that is like, how is your relationship set up with your pharmacist? So at OSU, for most of our clinics, we operate under what's called collaborative practice. So I have a set protocol for my clinic of what disease states I can manage, what meds I'm allowed to adjust. And so that becomes a little bit more of an update to the doc of saying, hey, here's where things are for this patient. Here's what I adjusted today. And then on the flip side, there's more consult based services where it's more coming directly to you and saying, here's what I found out. How would you like to do this? Or this is what I'm proposing. You really can tailor it to your comfort level, both personally and how much you know and trust the pharmacist that you're working with to manage some of these things. But I would say in general, pharmacists tend to be over communicators. So it's more likely you're going to get more of an update rather than less.
When I'm rounding at Riverside, which we're seeing consults in cardiology, and we often will have a pharmacist on rounds with us. But Megan, additionally, the arrhythmia clinics like class 3 monitoring, I know you're very involved with that. So do you feel that you're embedded in these different clinics or kind of an independent pharmacy clinic?
That's a really good question. And I also think it's a little bit of a loaded question. I think that I view myself as pretty independent in the antiarrhythmic clinic services that I have at Ohio Health. I I have a really good relationship with the providers that I work with, and I feel that I have pretty high trust from those providers in terms of the medication monitoring and so on and so forth. So again, I feel independent in that regard, but I also feel very integrated with that trust and that professional relationship that I've built. I think that the providers trust me to manage their patients and follow up appropriately without necessarily needing me to call on every patient. Again, similar to what Kelly described as the collaborative practice model, where I have a dedicated protocol and with the providers that manage the arrhythmias that allow me to do certain things. But again, there are certain things that go beyond that. Like if a patient needs an alternative rhythm strategy because they show failure, those are things that I've just learned over time and that adding to the the benefit of the patient overall to decrease recurrence of their atrial fibrillation and therefore decrease the risk of heart failure and vascular dementia over time. Of course, I want to be involved in that conversation and not just do the bare minimum. And so I try to incorporate that for myself. So I do feel very integrated with that team, but also I feel very independent in the practice model. So I think it's a dual answer in that regard. I also can speak to our anticoagulation services at Ohio Health, where I had initially started. Our providers across all of Ohio, we have 16 anticoagulation clinics at this time. And providers really trust the management of warfarin and other peri-procedural anticoagulation needs to those anticoagulation services. And so I really feel like the risk stratification and keeping up to date on needs of patients on anticoagulation are really, they have high trust in those providers and the communication when needed if there's a problem or making sure patients aren't at unnecessary risk of bleeding. It's definitely a provider to provider relationship, and those conversations happen definitely when needed.
I agree. I think it's both. It's both independence and being embedded and feeling like part of that care team. And like it's reasonable and easy if you have a question or a need or something beyond my scope or my area of expertise, knowing that the providers will welcome that discussion and then that collaborative approach to patient care. I think the other thing that you alluded to, Anne, is also having pharmacists on the inpatient side. And I think that's another piece where there's really good collaboration and integration is making sure that those pharmacists that are on the cardiology inpatient services know how to find me and vice versa so that there's better transition of care and handoff in that way, which also helps smooth, especially when our docs are going on and off service. It also helps make sure that the right message is getting to the right place as our patients transition inpatient to outpatient or vice versa.
Wow, this has been a great discussion of all the important roles that our pharmacists have taken on in managing our cardiovascular patients. Question for you, are there similar programs like these at all or most hospitals, or is this the minority and we're just starting to develop these programs across the country?
Yeah, so I think a lot of the bigger institutions or certainly academic institutions are more likely to have these type of programs or to have a broader reach of what pharmacy is doing. But even in places like primary care, a lot of primary care offices will have at least part of the week of pharmacists. So it is becoming more standard, I would say, for people to have at least access to a pharmacist, if not somebody that's doing this all the time. I think it's also important to think about what is most useful to you and to your institution. I know OSU, we tend to grow a little bit every year, but it's not always in cardiology. Sometimes it's in the connected pieces, like how do we connect these patients also through nephrology or through endocrinology to manage their diabetes and taking that more like big picture from a CKM standpoint. How are we addressing all of their risk to decrease their cardiovascular risks? Even if you don't have a pharmacist necessarily dedicated to you in cardiology, your colleagues that you're working with across disciplines may also have access to some of that and some of those resources as well.
Wow. First of all, thank you so much, Kelly and Megan, for joining us. Thank you, Anne, for co-hosting. I think that we all realize that teamwork is really the best way to provide the best cardiac care for our patients. And I think that our pharmacists truly have become an integral part of that team. I think until we have further discussions for another topic, Kelly and Megan, thank you so much for coming for today.
Thank you for joining today's podcast. For more information about the speakers or the topics, please go to ohioacc.org.